paper is a comparative study of the osteoporotic vertebral compression fracture treated with conservative percutaneous vertebroplasty and spinal reconstruction.
Good afternoon, everyone. Presenting our paper on comparative study of osteoporotic vertebral compression fractures treated with conservative vertebroplasty and spinal reconstruction. Osteoporotic vertebral compression fractures are a leading cause of disability and morbidity in the elderly. As stated by Hall et al., these fractures affect the quality of life, physical function, mental health, and survival. Increase in lifespan and desire to remain active, coupled with advances in spinal surgical techniques, has resulted in more spinal surgeries and given our patients early mobility. These fractures are basically treated with three modalities, that is conservative management, percutaneous vertebroplasty, posterior spinal instrumented stabilization. However, there are no studies studying all these modalities in a single state. So this study was conducted to overview the clinical and functional outcomes of all these three modes in these fractures. Our aim was to evaluate the clinical and functional outcomes, safety, and effectiveness of all these three different modalities. The inclusion criteria were thoracolumbar osteoporotic vertebral compression fractures and T-score below 2.5. We have excluded spinal infections and pathological fractures secondary to primary or metastatic tumors of the spine. The study was conducted at Sancheti Institute of Orthopedics and Rehabilitation during 2014-2017. 96 patients were selected. It was a prospective type of study, and patients were divided into three groups. The first group, the conservative type of group, the inclusion criteria were fresh and stable fractures without neurodeficit and radicular pain, without major disability, no sagittal imbalance. The second group, the percutaneous vertebroplasty group, the inclusion criteria were severe back pain failing conservative therapy, development of pseudoarthrosis on the X-ray, maintained sagittal alignment without bony propulsion or cord compression. The third group, operative group, in which we operated patients with stabilization or with or without cement augmented screws, with or without decompression. The inclusion criteria were bony retropulsion with neurological compromise, associated spinal instability and severe disability, loss of sagittal and coronal balance, and multiple level fractures. We have used three scores: visual analog score, modified osteoporotic disability index, and SF36 score. We have classified our fracture by Ginat et al. Into mild, moderate, and severe. We have assessed our patients with the help of history, clinical examination, VAS score and modified osteoporotic disability index, X-rays, MRIs, and DEXA scan. Presenting our first case, a 55-year-old male presented to us with the severe back pain, had a road traffic accident 6 days back. He was not having any low limb radiation or neurodeficit. Patient had sustained L4 wedge compression fracture. Patient completed our criteria of group 1, that is fresh stable fracture, no neurodeficit, no radicular pain, no sagittal imbalance. So patient was treated with bed rest and brace immobilization, pain control in the form of NSAIDs, mild opioids, anti-osteoporotic treatment in the form of injection teriparatide and bisphosphonates. Once the patient was relieved of pain, we have given early mobilization to the patients with the core strengthening exercises, lower back exercises, and the endurance exercises. Presenting our second case, 60-year-old female had a sudden jerk while traveling. Patient was treated conservatively for 2 months, no relief. Patient was having pain while getting up and turning in the bed. Patient had sustained L1 vertebral fracture with pseudoarthrosis. Patient had completed our criteria of group 2, that is severe back pain, pseudoarthrosis was present, and sagittal alignment was present. So patient was treated with cement augmented vertebroplasty. Presenting our third case, 68-year-old male. Patient had severe back pain after fall at home. Patient lost his bladder and bowel function. Also, bilateral hip weakness was present. Patient had D12 fracture with cord edema. Patient also has loss of sagittal balance. Patient completed our criteria of group 3, that is bony retropulsion was present, neurodeficit was present, loss of sagittal balance was present. So we treated patient with D9 to L4 posterior instrumented stabilization and D11 to L1 decompression. Whenever we felt in the osteoporotic fracture, the hold of the screw was poor, we went higher up, we used cement augmented screws, we did vertebroplasty at the fracture site, and the kyphosis and the deformity was corrected with the rod and screws. Presenting our last case, a 63-year-old female with severe back pain, inability to stand and walk independently. A patient had D12 fracture with cord compression, so completed our criteria of group 3, so operated with D9 to L3 posterior instrumented stabilization. We have seen grade 2 being the most commonly encountered fracture. 71% of our sample size had single level fracture. We have seen the statistically significant improvement in the VAS scores in all 3 groups at the end of 1 year. Also, modified osteoporotic disability index have shown a significant improvement at the end of 1 year in all 3 groups. The both components, that is physical and mental components of the SF36, have shown significant improvement at the end of 1 year. 2 of our patients had delayed wound healing. 2 of our patients had dural tear while decompression. Vertebroplasty, the timing, have been debated a lot in the literature, but Layton et al. Has suggested at least 3-month period should be waited before going for vertebroplasty. But Chen et al. And Lowy et al. Has advised 6 to 8 weeks of waiting period is enough. In our study also, we feel 6 to 8 weeks is sufficient for going for vertebroplasty. Old et al. Have suggested that if the conservative management executed properly with proper selection criteria to the patients, it gives excellent results. Sebastian et al. Says that if cement augmented screws are used, then it prevents screw loosening. In our study also, we have not seen any screw loosening at the end of 1 year. Hence, to conclude, if indications or contraindications for each treatment modality are considered carefully, if the tailor-made and fixed algorithm is used, then osteoporotic vertebral compression fractures gives excellent results. As suggested by our primary authors in 2015 by Dr. Ketan Khurjekar et al. In Oncology Journal of Orthopedics, and 2011 by Dr. Hadgaonkar in JOR, if vertebroplasty is appropriately used, it gives early pain relief and improved early VAS scores. Not every fracture needs intervention. Conservative and treatment executed properly also gives satisfactory outcomes in properly selected patients. Thank you.
It's open for question only, one question only. Yes, just any query?
Myself, Dr. Sarang.
Yes.
Have you seen any cement leak, any complications related to the cement leak?
No, sir, we have not seen any cement leak in our studies because we have repeated, all the surgeries were performed by a senior orthopedic surgeon. And for the vertebroplasty, we waited till the cement becomes duffy, feel like, and we have used radiopaque dye prior to the cementation. So whenever leak was present, we have waited. And gel foam, our technique published in 2011 by Dr. Hadgaonkar, gel foam technique in which we crush the gel foam, make a paste, and sinuses in the vertebra which gets fulfilled by that. And then vertebroplasty with the cement was done. So we have not seen any cement leakage, sir.
Thank you. In group 3 patients, you had done a decompression, all patients?
No, sir. 34 patients were operated with surgery, out of which 12 patients were operated with decompression. And rest,
what was the criteria in
yes,
these cases?
if there was cord compression and bony fragment compressing on the cord, then we have decompressed that fragment. Otherwise, indirect decompression was most of the time achieved.
But in all cases, we have retropulsion na, in group 3. And
No, sir.
neurodeficit.
There are 4 or 5 criteria I have shown. First criteria was definitely retropulsion. Second criteria was neurodeficit. Third criteria was severe pain with multiple level, and fourth criteria was multiple level fracture. Fifth criteria was pain which was not getting relieved by any conservative or vertebroplasty. Then we have chosen that operative criteria, sir.
Thank you.